Hi, everyone, and welcome to our training on grave disability and DBH resources. I am Julie Hale. I'm a Deputy Director of Program Support Services Division here at the Department of Behavioral Health. We're going to provide an overview of the Senate Bill SB 43 and the impact of grave disability, behavioral health options, the Lanterman-Petrus short conservatorship process refresher, and also San Bernardino County resources. So just to refresh, Senate Bill 43 was approved by Governor Newsom in 2023, and counties were provided a couple of years until January 1st of 2026 to implement SB 43 and the expansion of grave disability in their county. And this expansion of grave disability is under the Lanterman-Petrus Short Act. It expands the reporting requirement to include the number of persons admitted or detained for conditions that include grave disability due to a mental health disorder, severe substance use disorder, or both a mental health and a severe substance use disorder. It modified the hearsay evidentiary standards for conservatorship hearings to expand the array of testimony that can be submitted into conservatorship proceedings without requiring in-person cross-examination. It also requires entities who may refer patients for conservatorship or conduct conservatorship investigations to consider less restrictive alternatives, such as assistant outpatient treatment, more informally known as Laura's Law, and Community Assistance Recovery and Empowerment Court, known as Care Court. What is the impact of Senate Bill 43? To implement Senate Bill 43, counties have needed to develop an extensive array of new policies, procedures, workforce, treatment capacity, requires a further in-depth analysis to understand the full scope of state and local secondary guidance and other changes that will be required to support full implementation. Because SB 43 has not come with state-dedicated funding to support these expanded obligations, counties will need and have needed additional lead time to arrange for staffing and resources and that coordination of care necessary to support implementation. This change in policy significantly expands the portion of the population potentially subject to detention and conservatorship under the LPS Act from around 1% to around 10% of the population, as the definition of grave disability will now include those who are gravely disabled due to a severe substance use disorder. So let's review grave disability. Grave disability from the late 60s up until recently with the implementation of SB 43 has been defined as a condition in which an adult, as a result of a mental health disorder, is unable to provide his or her basic personal needs for food, clothing, and shelter. A gravely disabled minor is one who, as a result of a mental health disorder, is unable to utilize the elements of life, which are essential to health, safety, and development, including food, clothing, and shelter, or even though provided to the minor by others. So what does grave disability look like now? So the very bottom box, you will see that the criteria for grave disability for minors has not changed. What has changed is grave disability requirements for an adult. So due to a mental health disorder, a severe substance use disorder, or a co-occurring mental health and severe substance use disorder, an adult is unable to provide for their basic personal needs regarding food, clothing, and shelter, personal safety, defined as the ability of one to survive safely in the community without involuntary detention or treatment, medical care, care needed to prevent serious deterioration of an existing physical, medical condition which, if left untreated, is likely to result in serious bodily injury. Grave disability now. So if there is evidence of a mental health disorder, a severe substance use disorder, or a mental health disorder and severe substance use disorder, and the behaviors have the effect of grave disability, meaning the inability to provide for food, clothing, shelter, personal safety, and necessary medical care, and the individual is unwilling or unable to receive treatment voluntarily, then the individual may be a candidate for an involuntary hold. So how do we determine grave disability? The areas to look out for and assess for, but are not limited to, extreme examples of the following: inability to engage in personal hygiene, unwillingness to clothe oneself when clothing is provided, signs of severe malnourishment, including loss of weight or dehydration, unwillingness to eat when food is provided, inability to articulate a plan for getting food, extreme beliefs about food that is available, which could include a belief that it is poisoned, and so they refuse to eat it. Unable to utilize shelter when provided or formulate a reasonable plan for shelter. Inability to utilize medical care when needed and available. Wound care and infections that are likely to lead to loss of limb, possibly loss of life if not treated. Untreated life-threatening comorbidities, meaning that they have multiple medical conditions or diseases happening at the same time and are not receiving treatment. Running in and out of traffic, failure to thrive, unhygienic, uninhabitable conditions at home, or other home safety issues. Multiple near-fatal overdoses requiring inpatient hospitalization. A special note, Narcan reversals alone would not meet this criteria. Inability to care for hygiene, cleanliness, needles, which leads to illness. An individual incapable of defending themselves against ongoing victimization. Probable cause would not be met by any of these examples on their own, but instead the totality of the person's situation. So being unhoused or having a substance use disorder in and of itself is not sufficient to constitute grave disability. Subjective and objective observations from collateral, meaning family members or people close to the individual, and or self-supporting reporting accounts of functioning impairments are to be considered in the evaluation process. Even though they are insufficient for probable cause alone, collateral information is additional support information. Determining grave disability, let's talk about the diagnosis of severe substance use disorder briefly. A mental health, severe substance use disorder, or a co-occurring mental health substance use disorder diagnosis is not necessary at the time a 5150 is written and would instead be a part of an ongoing clinical assessment and treatment process, likely in an LPS hospital or in conjunction with a DBH program. Neither clinical nor non-clinical professionals encountering potential grave disability in the field are required to identify whether the primary cause is mental health and or severe SUD, regardless of which type of diagnosis is behind the grave disability. It is the responder's role to identify whether the individual's presentation at that time meets any or all of the 5 grave disability criteria. which are to refresh unable to provide for their own food, clothing, and shelter, personal safety, or necessary medical care. A diagnosis of severe SUD would need to be determined by a clinician working within their scope of practice. The clinician will also consider the chronic nature of the individual's condition and the historical course of the illness. Let's look at some behavioral health options. So for those working in a hospital or a hospital emergency department, over on the far left-hand side in the first box, let's say the patient is medically cleared. Moving to the right, the hold is determined to be valid and the patient declines voluntary treatment. What are the options? Patient either remains in the ED, is admitted into a psychiatric inpatient bed, or is transferred to an LPS designated hospital. Underneath that, if no LPS bed is available, patients would likely remain in the non-designated hospital or facility until the LPS bed is found, or the hold expires, or the criteria changes. If the patient does not stabilize after 72 hours, then, depending on the type of facility, for LPS designated providers, the LPS facility could initiate a 5250, which is for additional 14 days for treatment and evaluation, a referral for temporary conservatorship or TCON if available, and that must be made prior to day 14. For those that are in non-LPS designated providers, notify DBH patients' rights if the patient is not released within the 72 hours, and that is according to Assembly Bill 2275. Behavioral health options in the field. So let's say law enforcement responds to a reported behavioral health crisis. We could be looking at an involuntary hold under criteria for 5150, which include danger to self, danger to others, or grave disability. If it is suspected that the person meets grave disability criteria, one of the options is to contact DBH field-based team to consult and partner. Off to the left in the green oval, if grave disability is established, then an involuntary hold, a 5150, is written. Moving to the right, has a qualified professional medically cleared the individual? If no, medical clearance must be obtained and/or medical stabilization is required. If yes, identify inpatient bed appropriate for presenting condition. Going back up to the oval grave disability being suspected at the top. If a DBH, the option for contacting a DBH field-based team to consult and partner. Moving up to the right, if no grave disability is established, then connect with appropriate resources.
Hi, I am Miriam Clark, and I'll be highlighting resources and scenarios throughout this presentation. Let's get started. The following are field-based teams available through the Department of Behavioral Health. These field-based teams may be viable options to help divert individuals from jail or hospitalization. Our first field-based team is the Community Crisis Response Team, which is a community-based mobile crisis program for those experiencing a behavioral health crisis. Services are available 24 hours a day, 365 days a year, including holidays. Then we have our Triage Engagement and Support Team, known as TEST. These are co-located DBH mental health professionals within key agencies throughout the community, including sheriff's departments, police departments, emergency departments, probation departments, and college campuses. Staff respond in the field with law enforcement personnel and/or assist other partnering agency staff in managing behavioral health crisis in the field. Then we have our community outreach and support team known as COAST. These are mobile crisis code response units, which include a DBH test mental health professional, a firefighter emergency medical technician, a therapy canine, and a plainclothes specially trained police officer. Then we have our innovative remote on-site assistance delivery, known as Inroads, which provides street-based treatment for mental health, substance use disorders, and medical issues to residents experiencing both homelessness and severe mental illness. This is a multidisciplinary engagement team which includes law enforcement to serve mutual clients, however, does not respond to crisis situations. And then lastly, we have our homeless outreach and support team known as HOST, which is co-located with law enforcement and provides outreach engagement, housing navigation, and referral to community supports to individuals experiencing homelessness and mental illness. This team partners with law enforcement to serve mutual clients, however, does not respond to crisis situations. In the next couple of slides, we will have some scenarios developed by law enforcement that can help us determine if someone would be appropriate for Welfare Institution Code 5150 hold under the new expanded definition of grave disability. So let's get started. You are called to a welfare check of an elderly woman who had reportedly not been seen by neighbors in several days. Upon arrival and after receiving no response to knocks at the door, you enter the home through an open window. You discover the woman sitting in the living room in a recliner. Her clothing is soaked in urine and feces. Numerous piles of dog feces and stains consistent with dog urine are found in the home. The woman is awake, but so intoxicated that her words cannot be understood. Dozens of empty pot or vodka bottles are strewn across the floor, and a deceased and decomposing dog is found laying near the back door of the home. During the investigation, you locate a phone number of the woman's adult daughter and call her. The daughter reports that her mother is a hardcore alcoholic, and all family efforts to help her have failed. The daughter reports that her mom had worked as an accountant for several years, but lost her job months before due to her drinking issues. The daughter further reports that her mother's bills have gone unpaid, and she is now facing possible foreclosure on her home. The daughter also expresses concern that her medical stability, reporting that she has heart issues and high blood pressure, but refuses to seek medical attention and has not been taking medications for several months. Because of her drinking, family has stopped communicating with the elderly woman, and her daughter said everyone in the family had pretty well resigned themselves to the fact that she would simply drink herself to death. A record check reveals that the woman has no criminal history, no history of arrest, and no history of 5150. There have only been 2 police calls to the residence, both initiated by the female reporting loud noise in the neighborhood. No evidence of drug use is found. The woman's daughter reports no mental health history, and no medication used to treat mental illnesses are found. The woman is transported to the hospital's emergency department for treatment. Several hours later, she leaves the hospital against medical advice, and an additional call for service is created. You respond and find the female sitting outside a convenience store a few blocks from the hospital. She is drinking from a small bottle of Potter's vodka and refuses to return to the hospital for medical treatment. Would this individual be appropriate to detain pursuant to Welfare Institution Codes 5150 based on the existing LPS law or the expansion of LPS law pursuant to SB 43? What is the appropriate action to take in this scenario? Should you arrest the individual, write a 5150 hold for grave disability, write a 5150 hold for danger to self, or do nothing? All factors indicate that this person is suffering from a severe substance use disorder. Considering age, physical conditions, and obvious overuse, refusal to accept family support, refusal to accept medical services, historical issues, and more, criteria are met. A 5150 hold for grave disability under expanded SB 43 criteria is appropriate. In this second scenario, we have a deputy working in Yucaipa who is dispatched to a suspicious vehicle in the city park after hours. The reporting party, a park employee, observed an individual sitting in a red sedan near a ball field. The employee approaches the vehicle and observed a single male occupant who appeared to be unconscious. Upon arrival, the deputy discovered a single male in the driver's seat. The deputy observed a hypodermic needle in the individual's arm and burnt residue of a suspected heroin on the cup base of a soda can. The deputy is unable to awaken the individual and deploys 2 canisters of Narcan. The individual is then roused from his unconscious state, and after refusing services from the fire department and signing an AMA, is released to the deputy for disposition. A records check shows that the individual has been arrested once 2 years before for possession of heroin, but has no other arrest or police contact history. The deputy is unfamiliar with the individual. During his investigation, the deputy discovers the male lives nearby and works in construction. A search of the individual reveals a usable quantity of heroin in his pocket. The individual has no known mental health history, no history of 5150, and reports no medical or mental health concerns. Would this individual be appropriate to be detained pursuant to Welfare Institution 5150 based on the existing LPS laws or the expansion of LPS laws pursuant to SB 43? What is the appropriate action to take in this scenario? Do we arrest the individual? Write the 5150 hold for grave disability, write a 5150 hold for danger to self, or do nothing? Arrest the individual. This would not be appropriate 5150 under the current or expanded criteria. This individual, though at least temporarily unconscious and unable to care for himself, has no documented history in support of several substance use disorder and no other factors indicative of grave disability. Arrest for the heroin charge would be the appropriate disposition. And our final scenario, we have a deputy assigned to the Sheriff's Hope Team who is conducting a proactive outreach at a small homeless encampment located under the 210 freeway near the Highland Avenue exit. While working with the individuals in the camp, the deputy discovers a nude male unconscious in the brush near the camp. The male has no identification and is unresponsive. The deputy observes numerous bleeding sores on the individual's arms and legs, some of which are clearly infected. Medical aid responds and deploys Narcan with no results. Other residents identify the male as John Smith, and a record check confirms that identity. The individual is transported to the hospital. During their investigation, deputies discover the individual has been sleeping on a cardboard mat just outside the camp. He has no blankets or other covers. It is January and nighttime lows have been near freezing. Paraphernalia consists with methamphetamine use, and numerous empty alcoholic beverage bottles are located near the cardboard mats. Residents in the camp report the male has been drinking and using drugs heavily and has reported seeing and hearing things that are not there, and on occasion talking to himself or the air. The male has reportedly been violent towards others and reportedly assaulted another male in the camp just hours before the deputies arrived. The victim of the reported assault could not be located. A records check shows the individual has been taken 5150 by deputies 3 times in the last 6 months and had been arrested on various drug charges 4 times in the last year. Hope records show 13 prior contacts with the individual over the last year, with each resulting in a refusal to accept mental health or housing services. A Laura's Law case had recently been generated on the individual, and the matter was pending arbis review. The individual was also found to have a felony warrant for burglary and a separate warrant for felony probation violation. Arrest records indicate the male was 6 feet tall, 180 pounds at the time of his last arrest, some 6 months before. But the deputy's observation now placed the man at an estimated 120 pounds. The deputy responds to the hospital, and after the individual is stabilized and medically cleared, prepares to take the man into custody. Would this individual be appropriate to detain pursuant to Welfare Institution Code 5150 based on the existing LPS laws, or the expansion of LPS laws pursuant to SB 43? What is the appropriate action to take in this scenario? Should we arrest the individual, write a 5150 hold for grave disability, write a 5150 hold for danger to self, or do nothing? This is a trickier one. Does it appear that the individual has severe substance use disorder? Yes. There is extensive history of use, numerous arrests, apparent overuse, and health and safety concerns potentially related to use. It also appears this individual is gravely disabled based on existing criteria: nude, unconscious in the brush, evidence of assaultive behavior, evidence of destructive substance abuse, health and safety suffering, refuses services, etc. 2 felony warrants. Could this person be a candidate for grave disability 5150? Yes. Due to the severe substance use disorder and other presenting issues. However, considering his assaultive behavior and 2 felony warrants, arrest may be a better choice, with jail mental health services handling the other issues and referring him to ARMC CSU at the time of release.
My name is Kelly, and I'm a clinical therapist too with the Office of Patients' Rights, and I will be discussing Assembly Bill 2275. This bill was approved and chaptered on September 30th, 2022. It went into effect on January 1st, 2023. AB 2275 specifies that the 72-hour period of detention begins at the time when a person is first detained. It requires any facility that detains a person pursuant to WIC 5150 to notify the county's patient rights advocates if a person has not been released within 72 hours of the hold. AB 2275 allows for due process. A certification review hearing is required to be held within 7 days of the date of detainment when a person has not been certified for 14-day intensive treatment and remains detained on an involuntary hold. A certification review hearing is an informal hearing that decides if a facility has probable cause to detain a person as danger to self, danger to others, or gravely disabled due to a mental disorder. The hearing assesses the validity of the detention and ensures that the person's rights are protected. In a certification review hearing, the patient's condition, treatment, and legal rights are reviewed by a hearing officer, the doctor who's representing the facility, the patient's rights advocate, and the patient if they so choose to attend. This regulation requires the person in charge of the county designated facility or individual designated by the county if the person is not in a designated facility to notify the detainee of specific rights. Assembly Bill 2275 extends the right to a writ of habeas corpus to every person detained under this part if held in any facility longer than 72 hours. It may be requested before or after the certification review hearing. A writ of habeas corpus is a formal request to the Superior Court to be released from detention. Usually occurs when an individual disagrees with the decision that is made during a certification review hearing. It allows the individual to file an appeal of the hearing officer's decision and take the challenge to court to be heard by the judge. And it can only be requested by the patient or patient's representative or advocate. The writ hearing is a formal court hearing officiated by a superior court judge, and the patient will have an attorney prepare and represent them at this hearing. The individual is then brought before a superior judge to determine if there are lawful grounds for them to be held in the facility.
The following are voluntary Department of Behavioral Health resources for substance use disorders. These resources are available to the public, and individuals may be referred directly to these services and programs. The first resource is our outpatient clinics, which provide ongoing medication support, therapeutic interventions, and linkage to resources. Next, we have intensive outpatient treatment. These are treatment services which provide individual and group counseling in an outpatient setting for a minimum of 9 hours of treatment per week and a maximum of 19 hours per week. These are services that are provided specifically to our pregnant and parenting clients, along with therapeutic interventions for children. Our Narcan treatment program is medication-assisted treatment for opioid substance use disorders, offering a medical evaluation and counseling services. We also have early intervention services, which target youth ages 12 to 17 and adults ages 18 through 20 who are at risk of developing substance-related or addictive behavior problems. Continuing with our voluntary substance use disorder resources, we have medication-assisted treatment, which is also available for substance use disorders, offering medical evaluation and counseling services. We have recovery services, which provide emotional and practical support for continuing recovery, as well as daily structure and rewarding alternatives to substance use. We also have recovery centers, which are community-based service centers whose primary purpose is to support recovery efforts from substance use disorders, offering self-help groups, healthy socialization opportunities, and education. Lastly, we have environmental prevention, which are efforts aimed at changing community standards and attitudes that shape behavior, which makes it easier for people to act in healthy ways. Their environmental prevention goal is to prevent or reduce substance use and other behavioral health conditions within the community. Now let's look at the voluntary behavioral health resources specific for mental health. Once again, these services are available to the public, and individuals may be referred directly to these programs. First up is our crisis stabilization units and our crisis walk-in centers. These are voluntary mental health urgent care services provided on a walk-in basis for individuals of all ages. Services last less than 24 hours, and facilities are open 24/7. Crisis residential treatment. These are voluntary residential services in a community-based home-like environment where a client can stay for up to 90 days. We also have outpatient clinics, which provide ongoing medication support, therapeutic interventions, and linkage to resources. We also have boarding cares, which are licensed facilities that offer boarding care services to individuals who can manage their basic needs but require assistance with medication reminders or basic hygiene practices. Clients utilize their own funding. Lastly, for voluntary behavioral health resources, we have room and boards. Room and boards provide community-based independent shared rooms for individuals who can manage their own medications and live independently in a congregate setting. Clients utilize their own funding. Now let's discuss the unlocked Department of Behavioral Health referred resources. These are voluntary resources for which Department of Behavioral Health maintains contracts for services. Placement is arranged via authorization by the Department of Behavioral Health Screening Assessment and Referral Center, known as SARC, for substance use disorders, or through the Department of Behavioral Health's long-term care team, known as LTC, for mental health. These services include substance use disorder residential treatment. These are substance use disorder services provided in a home-like setting while attending treatment services such as group counseling, individual counseling, alcohol and drug education. All residential treatment services receive prior authorization by the Department of Behavioral Health Substance Use Disorder and Recovery Services. Then we have withdrawal management, which provides monitored detoxification services in a residential treatment or hospital setting. We also have enhanced boarding cares. These are licensed facilities that offer boarding care services as well as additional enhanced support services to assist adult clients maintain stability in the community. Enhanced services include providing for any special medical needs, assisting consumers in planning, arranging, and transporting to appointments, social educational groups, medication support, and deaf hearing impaired services. We also have adult residential treatment licensed facilities certified to provide social rehabilitation model services to adult consumers living with a behavioral health condition. These are unlocked residential treatment facilities offering a stable, highly structured treatment program in a community home-like setting. Services can be long-term up to 18 months or transitional up to 12 months. Then we have enhanced assisted living, licensed adult residential facilities that provide comprehensive medical care to adult and older adult consumers experiencing a comorbid medical or behavioral health condition and require support and monitoring to ensure their stability. The following resources are unlocked court-referred resources. Individuals must be referred through the Superior Court for these specific substance use disorder services. These services include drug court, which provides a structured, monitored substance use disorder treatment program for adults who are referred by the Superior Court. Then we have the Driving Under the Influence DUI program, which provides education and individual interactive group counseling for referral resources for adults. Referrals must originate from the Superior Court or DMV. And we also have Deferred Entry of Judgment, DEJ program, which provides understanding of education process to encourage recovery from drug for adults. Referrals must originate from the Superior Court. The following resources are locked Department of Behavioral Health referred resources. Placement in these facilities must be arranged by referrals to the Department of Behavioral Health's long-term care program. These programs include the Skilled Nursing Facility, known as SNFs, licensed facilities who specialize in serving persistently mentally ill adult clients who have complex medical conditions. These facilities provide inpatient medical and psychiatric components that provide programs of organized therapeutic activities. SNF services also support clients who experience dementia-related disorders in addition to their behavioral health condition. Then we have mental health rehabilitation centers, licensed long-term facilities categorized as an institution for mental disease, IMD, who provide activities to assist the client to return to a less structured facility. Facilities serve adults ages 18 to 65 whose functioning is too low to be maintained at a licensed boarding care, including enhanced boarding cares. Then we have Institution for Mental Diseases, IMD, licensed facilities which specialize in providing programs for organized therapeutic activities and designed to improve functionality in daily living and social skills for clients with severe mental health conditions. These facilities serve adults ages 18 through 64 whose functioning is too low to be maintained in a boarding care or enhanced boarding care facility. Lastly, we have state hospitals, the highest level of locked psychiatric care. These clients have been committed by the criminal court, ordered through penal code commitments, offenders with mental health disorders, and LPS conservatorship. Lastly, the following are other resources available to hospitals, emergency departments, and or law enforcement for individuals with behavioral health illnesses. We have Recovery-based Engagement Support Team, known as RBEST, which is a field-based team who provides support to and engagement with individuals who are unwilling or unable to seek or receive treatment due to the symptoms of their mental illness. Services pertaining to assisted outpatient treatment, known as AOT, and the Community Assistance Recovery and Empowerment CARE Act may be available through the RBEST engagement process. Then we have our Emergency Department Healthcare Navigation Team. Pre-enhanced care management teams with two main goals: to enroll eligible individuals into ECM, currently only partnered with IEHP, and to link individuals in the emergency department with behavioral health concerns to the Department of Behavioral Health, outpatient clinics, or substance use disorder resources. Teams can go to the emergency department while the patient is there to assist with follow-up linkage, including scheduling outpatient mental health appointments, enroll IEHP members into ECM if not enrolled, and assist with connecting and individuals to their ECM team.
Hello, I'm Dr. Jonathan Avalos, an addiction medicine physician serving as an associate medical director for the Department of Behavioral Health. I'm going to be sharing with you some resources related to the treatment of substance use disorders for hospitals and emergency departments. The first resource I'd like to share with you is the National Clinician Consultation Center Substance Use Warm Line. This service offers free, confidential, clinician-to-clinician telephone consultation for evidence-based treatment of substance use disorders, including evaluation and management. This service is available Monday through Friday, 6 a.m. to 5 p.m. Pacific Time, to any healthcare provider in need of specialty addiction medicine consultation. You may also leave a voicemail 24 hours a day, 365 days a year. This service may be reached by calling 855-300-3595. The next resource I'd like to share with you is the California Poison Control Center. This service offers free, confidential, telephone-based information, advice, and treatment recommendations. This service is available 24 hours a day, 365 days a year. And by navigating through the telephone menus, you may be able to speak directly with a medical toxicologist if needed. You may access this resource by calling 1-800-411-8080. The next resource I'd like to share with you is the California Bridge program. This program offers flowcharts, practice guidelines, and other resources related to the initiation of buprenorphine medication-assisted treatment, or MAT, in the hospital setting or in the emergency department setting, as well as procedures on how to link individuals initiated on that treatment into ongoing treatment in the community. The last resource I'd like to share with you is the American Society of Addiction Medicine, ASAM. Clinical Practice Guidelines. The ASAM Clinical Practice Guidelines offer evidence-based, vetted, current treatment guidelines on the management of substance use disorder, including alcohol use disorder, stimulant use disorder, and opioid use disorder, as well as others. I would recommend familiarizing yourself with this resource if you treat individuals with substance use disorders in the hospital or emergency department setting. Thank you very much.
So let's review the LPS conservatorship process. An LPS conservatorship is for a person who is gravely disabled as a result of a mental health disorder, a severe substance use disorder, or co-occurring mental health and substance use disorders as of April 1st, 2025 in San Bernardino County. An individual is not considered gravely disabled if they can survive safely with the help of responsible others who are willing and able to help them. Individuals have a right to a jury trial on the issue of grave disability. Grave disability must be established beyond a reasonable doubt. So who can refer for an LPS conservatorship according to the law? A psychiatrist providing treatment in one of the 5 LPS designated psychiatric hospitals in San Bernardino County can recommend a patient who is receiving treatment in the facility for LPS conservatorship. A petition packet with required exhibits, including signed declaration of the physician and signed recommendation, are sent to the DBH Conservatorship Investigation Unit, or the CIU. A temporary conservatorship, TCON, determination must be made prior to the end of the 14-day hold if the patient is in an LPS designated inpatient hospital. Packets are generally sent on a 4 or 5 day basis after the patient has been stabilized on medication. Psychiatrists treating patients in county detention centers may also refer individuals for an LPS conservatorship with the petition packet noted above at any time during the individual's incarceration, once they have determined that the individual is gravely disabled. So let's look at a flow chart of the process. In an LPS designated hospital in San Bernardino County, let's say somebody is there on a 72-hour hold known as a 5150. If they are referred and meet criteria for a 14-day hold, a 5250, then the treating physician submits a referral to DBH Conservatorship Investigation Unit, or the CIU. The CIU investigates temporary conservatorship, or TCON. They're evaluating whether the criteria are met. Let's say the criteria are not met for temporary conservatorship. Then off to the left, you see the LPS unit or detention center finds other options. Moving down, let's say a temporary conservatorship, a TCON criteria is met. Then a hearing is held. Is the temporary conservatorship or TCON granted? If yes, the Office of the Public Guardian is designated as the conservator. If no, then the patient is released. So you'll see in between, after the TCON has been finalized, permanent LPS conservatorship process may be initiated. You'll see in the red box that goes with the asterisks in the 14-day hold and the TCON hearing boxes that if the patient objects to either the 5150 or the temporary conservatorship, they may request a writ hearing.
In the next few slides, we will quickly review the available resources in San Bernardino County that have been highlighted throughout this presentation. We will also provide you the contact information to these services. On this slide, you will see the 5 LPS hospitals in San Bernardino County. The following LPS facilities currently serve adults. These include Arrowhead Regional Medical Center in Colton, Community Hospital of San Bernardino, and the Jerry Petrus Memorial Veteran Hospital, which serves our veteran population. The following LPS facilities serve adults and adolescents. These include Canyon Ridge Hospital in Chino, Loma Linda Behavioral Medicine Center in Redlands. Please note that Loma Linda Behavioral Medicine Center is the only LPS facility that serves children. The following are voluntary crisis services which have already been covered. However, I wanted to remind you that these are viable options that can help support and divert individuals to less restrictive care settings. I encourage you to contact our community crisis response team and to utilize our crisis stabilization units, crisis walk-in centers, and crisis residential treatment facilities whenever possible. On this slide, you will see our mental health outpatient clinics, which are available throughout San Bernardino County. These clinics are located throughout the East Valley and West Valley regions. And on this slide, you will find the mental health outpatient clinics throughout the desert and mountain regions. Furthermore, we would like to highlight our substance use disorder outpatient clinics throughout San Bernardino County. These clinics are available in the East Valley and West Valley of the county, and our desert and mountain regions. Please note that our substance use disorder recovery services administrative contact information is also provided should you need more information on additional substance use disorder services. Lastly, on this slide, you will see services on the left that are available to help engage and connect individuals into the Department of Behavioral Health system of care, while the services on the right are specialty services to help engage individuals who are unhoused. As we finalize this presentation, I would like to highlight once again the 3 main contact numbers where an individual can get connected into services: our Access Unit Behavioral Health Helpline, our Screening Assessment and Referral Center Substance Use Disorder Helpline, and our Community Crisis Response Team. To obtain more information on Senate Bill 43, we invite you to visit our website or to scan our QR code on this slide. I hope you found today's presentation informative and useful. Thank you for joining us.